Okay, get this. What if a medication that's supposed to save your life could actually kill you? In this explainer, we're diving into a really critical medical paradox. It's a hidden danger that can lurk in the heart's rhythm, and it can turn a totally standard treatment into a fatal mistake. So, how is that even possible? I know, it sounds like a complete contradiction, right? But it's a very real and very serious clinical emergency. We're going to walk through the exact scenario where a common life-saving heart medication can go catastrophically wrong, and we'll uncover the surprising reason why it happens. To get to the bottom of this mystery, we first need to get to know a pretty specific condition. It's called Wolff-Parkinson-White syndrome, or just WPW for short. And this, right here, is the key that unlocks the entire puzzle. So what is WPW? Well, at its core, it's all about the heart's wiring. It just means there's an extra electrical pathway in the heart. You can think of it like a shortcut that electricity can take, a shortcut that really isn't supposed to be there. See, in a healthy heart, all the electrical traffic that travels from the top chambers down to the bottom has to pass through one single checkpoint. It's called the AV node. And you can think of it like a gatekeeper. Its entire job is to slow that signal down just a little bit to make sure the chambers beat in a safe, coordinated rhythm. But in WPW, there's a second path, this accessory pathway. And it's basically an unregulated electrical backroad. Any signals that traveled on this shortcut, they bypass that crucial gatekeeper completely, which means they can get to the lower chambers way, way too fast. Okay, so you have this electrical shortcut. How does it become lethal? Well, the danger really ignites when three things happen all at once. The patient has WPW, they develop a chaotic, super fast heart rhythm called atrial fibrillation, and then they're given a specific type of heart medication. And these are the drugs that create the perfect storm. Now, while they are often lifesavers in other situations, they are the absolute wrong choice for a WPW patient who's in atrial fibrillation. That's when their heart's upper chambers are just beating chaotically. All these drugs are what we call AV nodal blocking agents, which means their whole job is to slow down that normal gatekeeper. And you can see exactly how this disaster unfolds, step by step. First, the drug blocks the normal pathway, the gatekeeper. Second, this forces all of those chaotic electrical signals down that unopposed shortcut. It's the only way to go. Third, this unleashes an absolute electrical storm in the lower chambers. And the result? The heart's rhythm can degenerate into ventricular fibrillation, which is a quivering, ineffective state that is, for all intents and purposes, cardiac arrest. So the absolute key here, the million-dollar question, is how do you know this danger is even present before you give a medication? Well, it all comes down to learning how to spot the electrical clues on an electrocardiogram, an ECG. Now, this is where things get a little more detailed. That hidden shortcut can actually create two very different kinds of fast heart rhythms. They're both caused by a sort of electrical short circuit in the heart, but the direction the electricity travels through that circuit changes everything about how the rhythm looks and, more importantly, how dangerous it is. So first up is what we call orthodromic AVRT. This one's the most common. In this case, electricity travels in the normal direction, down through the gatekeeper. And because the lower chambers get that signal through the proper channels, the ECG shows a fast but pretty organized rhythm. The electrical spikes are narrow, which tells us the signal is traveling along the heart's normal electrical highway. The second one, and this is the one we really have to worry about, is antidromic AVRT. Anti means against the normal flow. So here, the electricity goes down the shortcut first, bypassing the whole normal system, and then it travels back up the AV node. And because it's going down that weird back road, it creates a wide, bizarre-looking rhythm on the ECG. This chart really breaks it down for us. Let's just focus on that antegrade limb row. That's just a fancy way of saying the path going down. You can see that in the common orthodromic rhythm, it's the normal AV node. But in the dangerous antidromic one, it's the accessory pathway. And that single difference is why one rhythm looks narrow on the ECG and the other one looks wide. And it's also why one mimics a much, much more dangerous condition. Okay, so this is where it all comes together. This brings us to the final and most important piece of the puzzle. This is why getting this right is, and I'm not exaggerating, literally a matter of life and death in an emergency room. And here's the kicker. The central challenge, the real trap for clinicians, is right here. Antidromic AVRT, That's the rhythm where those blocking drugs are deadly, can look nearly identical to a different lethal rhythm called ventricular tachycardia, or VT. So you're looking at a monitor, you see a fast, wide heartbeat, and you have to make a choice, fast. And this leads to one of the most important golden rules in all of emergency medicine. When you are faced with a fast, wide rhythm and you aren't 100% sure what it is, you must treat it as the most dangerous possibility just to keep the patient safe. As the guideline says right on the screen, if the diagnosis is unclear, it should be managed as VT. So here's the bottom line. Treating that antidromic AVRT as if it were VT is safe. But making the opposite mistake, assuming a wide rhythm is something it isn't and giving one of those AV nodal blockers, that can be fatal for the patient with that hidden electrical shortcut. That treat as VT rule protects them from that disaster. And that leaves us with the ultimate clinical challenge, doesn't it? It just highlights why understanding this hidden danger, this electrical backroad in the heart, is so absolutely vital for keeping patients safe. You know, it's not just about reading some squiggly lines on a piece of paper, it's about preventing a preventable tragedy.